Hello and welcome to the Patient-Centered Interest Group webinar from March 2025. My name is Neil Spooner. I'm the chair of the Patient-Centered Sampling Interest Group, and our speaker today is Alex Kitz, the Director of Science at SalivaDirect. Sorry, my voice is not working. The title of her talk today is Saliva as a Diagnostic Tool for Advancing Accessible Testing. But before we get started with Alex, just want to say a quick thank you to our partners and sponsors. Big thank you to the evidence base that give us this platform from which we have our webinars. And a big thank you to all of our sponsors who enable us to have all of these webinars every month. Please remember that this webinar is being recorded and in the next few days will be available on our YouTube channel and also through our website and through the evidence-based website. If you have any questions for Alex, there's going to be plenty of time, hopefully at the end of this presentation, for questions and answers. So please submit those through the chat function, which you can see on the right-hand side of your screen. And with no further ado, I'll hand you over to Alex. See you at the other side, Alex.
Thank you so much, Neil, for this very kind introduction. Yes, I'm Alex. I'm the Director of Science at SalivaDirect. SalivaDirect is a nonprofit in the US, and we are dedicated to enhancing public health through accessible testing strategies by developing and deploying innovative solutions that respond to evolving global health questions and challenges. And today I'm going to talk about how saliva can help us as a diagnostic tool for advancing accessible testing. There we go. Okay, I'll first give you a brief overview of the topics I'm going to cover today. First, the objective of the talk is to explore saliva as a sample type for diagnostics, what it is, how it works, its impact on healthcare. I'm going to touch briefly on the current challenges in diagnostics and also show some examples of scientific advances in saliva-based diagnostics over the last 20 to 25 years. And then we'll dive into how saliva can help to increase accessibility. Brief disclaimer, I'm a molecular biologist by training and focus a lot of my time on developing RT-qPCR-based assays, so it's a little bit biased towards that technology. First, the problem we identified is, although there are a lot of diagnostic mechanisms and technologies out there, there's still need for accessible testing. High-quality diagnostic testing can be a high barrier for test seekers based on their income, their geographical disparities, age groups, disabilities, and many diagnostic tests still use invasive sampling techniques, for example, the venous puncture blood draw or nasopharyngeal swab. These invasive sampling procedures heighten the risk of exposure to the healthcare professionals, and also based on the sample type and how it's obtained, many diagnostic tests are still unnecessarily expensive and often linked to inflexibility in terms of what kind of laboratory equipment can run the diagnostic assay. Saliva over the last couple of years, however, has emerged as an innovative and patient-friendly alternative with the possibility to overcome some, if not all, of these barriers and pitfalls. So let's dive into what is saliva. Hang on a sec. From a molecular makeup, saliva is a complex biological fluid that is naturally accumulating in your oral cavity. It mainly consists of water and electrolytes, with 90% of it being water, and contains key electrolytes like sodium, potassium, calcium, bicarbonates for osmotic balance and pH regulation. It also contains a lot of proteins and enzymes, for example, amylase for digestion and other enzymes that help with antimicrobial defense and lubrication. Also, we can find in saliva a variety of antibodies and cells. There's a lot of IgA for immune responses, as well as epithelial cells and leukocytes involved in oral defense mechanisms. And then on the flip side, there's the oral microbiome with a variety of naturally occurring bacteria, fungi, and viruses. Why do we focus on saliva as a sample type now? The collection process for saliva is very simple, non-invasive, and flexible. As you can see on the right-hand side here, the patient can just passively drool into a tube, and that is the whole collection sampling process. That makes the collection process itself more convenient for patients and allows for frequent retesting because of its non-invasive nature. And what we and others found in the last couple of years is that for viral respiratory infection, there's no RNA or DNA extraction step needed in a laboratory, which means that the lab process is very simple and still retains high sensitivity. You get very fast turnaround time of results, which is very important for pandemic responses. And the cost-effective collection and processing protocol makes it a very interesting workflow to a variety of laboratories. Additionally, specifically for nucleic acids, for DNA and RNA, it's been shown that they remain relatively stable for extended periods of time in saliva without any additive added to the sample, which opens up a whole lot of opportunities for decentralized testing and at-home collections. On this graph here, I show you SARS-CoV-2 RNA stability in non-supplemented saliva. So on the y-axis, we have the CT value for COVID, and on the bottom, we have on the left-hand side, different conditions like fresh saliva, frozen and thawed saliva, stored at room temperature for 5 days, and stored at 30 degrees for 3 days. And you can see that each line represents a sample that was aliquoted and stored at the different temperatures and time frames. And you can see that overall, most of the samples, the CT value remains stable across the different conditions. And on the right-hand side, we have a similar graph where we show an extended storage at days at room temperature up to 25 days. And again, samples remain relatively stable even over extended periods of time at room temp without any additives. Additionally, most recently, or over the last 20-25 years, it's been shown that saliva is a very versatile sample type that carries biomarkers for a variety of infectious diseases, infections and diseases. For example, we have evidence that respiratory diseases can be detected in saliva with COVID, flu, RSV, and strep A, but also other infectious diseases like oral sexually transmitted infections. There's publications that could show that cancer can be detected and cancer activity can be detected in saliva samples, both for oral and non-oral cancers. Saliva contains biomarkers for concussions, TBI, other neurological diseases, and mental health biomarkers. And also, it's been shown that it could be useful for monitoring women's health by monitoring hormone levels and endometriosis markers. Just to give you a brief summary of the benefits of saliva, in this table I compared saliva, blood sample, and swabs. This is a depiction of the nasopharyngeal swab. That's the one that, how people describe it, tickles your brain a little bit and goes all the way back. It's very uncomfortable. So it is not non-invasive, whereas saliva is non-invasive. Blood I listed at no, but most recently there have been advances on technology there so that it can be non-invasive and also be self-collected. Whereas with swabs, especially for the nasopharyngeal, a healthcare professional has to be involved in the process. Saliva can be self-collected, so saliva reduces the risk of exposure. For the swabs, that's dependent on what kind of swab. Saliva is cost-effective. It doesn't require any buffers. We can use raw saliva for a lot of downstream assays. And the complexity of lab processing can be low compared to blood and nasopharyngeal or generally nasal swabs. On this slide, I'm showing you the preference of sample method. It's a study that was conducted after the COVID-19 pandemic, and they collected survey data from about 2,100 participants across 125 countries and investigated which kind of sample type people prefer. And you can see, if we focus on North America on the top left here, that we have oral swabs, nasopharyngeal swabs, nasal swabs, oropharyngeal swabs, which is throat swabs, and saliva as the options. And the majority of people seem to prefer oral collection methods, and that's across the globe. And specifically, oral collection methods over the NP swab, which is the most uncomfortable. This is an example now how we and others used saliva to simplify laboratory testing processes. It's a COVID-RT qPCR based test, and you can see on the right-hand side here, again, we have saliva, which has a lot of molecules in it with its antibodies, cells, and everything. And in red, we highlight the SARS-CoV-2 virus. And in our workflow here, what we did is we add a protein called an enzyme called proteinase K, and that destroys a lot of the protein bonds and molecules within the saliva, but also destroys the viral capsule, subsequently releasing the COVID-19 RNA into the sample, which can then be detected by any common RT-qPCR instrument. Using this kind of workflow enables us to provide assays with very fast turnaround time. The cost of these is relatively low because there's no RNA or DNA extraction step involved, and it's a very easy setup, which means this simple workflow can be deployed easily to a large laboratory network in a short amount of time. And these simple workflows can also aid the creation of standardized protocols internationally and across the laboratory networks that are involved with testing. Over the next few slides, I'm going to show you a few real-world applications of saliva-based testing. As I mentioned before, there has been a steady increase in diagnostic interest in saliva as a sample type over the last 20 to 25 years. And this is the PubMed graph that comes up if you search for clinical diagnostics in saliva. The recent focus in the last 5 years, of course, was majorly fueled by the COVID-19 pandemic, and a lot of the publications are based around that. However, there's also been emerging evidence for the detection of other infectious diseases in salivas like STIs. So that's our first example as well. There are publications out over the last 10, 15 years that you can detect local and systemic STI infections in saliva samples. So for example, it's possible to detect oral chlamydia, gonorrhea, and associated antimicrobial resistance genes in saliva samples via PCR. That's depicted here as an example for chlamydia. On the y-axis, we have the copies of chlamydia genomic DNA in the different sample types. And then in this study, they looked at the posterior oropharynx swab samples, tonsillar fossae swab samples, and saliva. And although the copies in saliva are lower, it is possible to detect DNA in saliva, which is a very great starting point for assay development. The second example I wanted to highlight is syphilis detection in saliva. Syphilis is a systemic infection and can affect a variety of different organs if left untreated, and it's usually diagnosed using a blood sample or CSF. And in this graph over here, I just focus on all cases, although the study shows that it's in the different subtypes reliably detectable in saliva as well. But on the y-axis, again, you have the copies per milliliter of the genomic DNA. On the left-hand side for saliva, on the right-hand side for plasma. And you can see that the saliva levels are much higher than the plasma levels, and it's readily detectable in saliva. Other STIs that are detectable in saliva that I'm not showing any graphs for or images is you can detect HIV both in RNA form and in antibodies, HSV 1 and 2, and Mpox. So now we focus a lot on infectious diseases, and that came out of saliva being used as a tool for COVID-19 diagnostics. But interestingly, it's also possible to detect biomarkers for more chronic diseases in saliva. One example being that salivary glucose levels can be used to monitor diabetes. Cortisol and CRP can be used to monitor cardiovascular diseases, metabolites, enzyme levels, and their activity for metabolic disorders, and so on. And for cancer screening, both using DNA methylation as well as RNA expression levels, people have shown that you can detect non-oral and oral cancer. So on this left-hand study, they focus on head and neck cancer and tumor-specific methylation in saliva as a biomarker. And the group on the right-hand side, led by Dr. David Wong, focused on an RNA expression profile that differs between saliva samples of breast cancer patients versus healthy controls. So one thing I want to point out here, and that will come back later too, is that these publications have been done more than 15 years ago, or 15 to 20 years ago. So we have the knowledge of RNA expression profiles for a variety of cancers in saliva, but it never translated into the into the diagnostic space. Other markers that saliva is able to detect are alpha-synuclein for Parkinson's disease. And again, cortisol levels in saliva can be utilized for a variety of applications. For example, cortisol levels have been shown to be increased in concussions. So there are a variety of studies now across the globe looking at concussion injury in all the different sports like soccer, rugby, American football, and in traumatic brain injury where cortisol levels, interestingly, are increased. There are also studies that focus more on microRNA signatures, both in TBI as well as in concussion, as an additional value to monitor the progression of concussion, the progression of getting better from the concussion, and then subsequently being able to return to play the sport again after being cleared. Another real-world application of saliva-based testing is the potential for pharmacogenetic monitoring. Regular monitoring of drug levels in saliva allows for personalized dosage adjustment, and saliva can aid this due to its non-invasive nature, because it can be used for serial and repetitive testing. So it would help ensuring the drug effectiveness in this scenario. Saliva-based testing would aid in monitoring the drug levels and minimize side effects that come with that. And it would also encourage patient adherence due to the regular monitoring and the potential for at-home collections. And I just wanted to highlight this publication here from last year, where this group showed that you can isolate antidepressants and their metabolites from saliva as a way to monitor depression treatment and anxiety treatment. Okay, over the last couple of slides, we learned a lot about the real-world application of saliva-based testing. And we've learned that biomarker identification and technological advancements using saliva as a sample type have steadily increased over the last 20 years. And now I'm going to provide you a few examples of how we think saliva can aid in increasing the accessibility of diagnostic testing and how it can bridge the gap. One of those would be that the ease of self-collection and the proven sample stability, specifically for RNA and DNA without preservatives, makes saliva suitable for at-home collection advances and programs. So one avenue that we and others have been exploring is the distribution of collection kits through vending machines. The advantage of these vending machines, and an example is on the right-hand side here, are that they are accessible 24/7. They anonymize the testing process, which can reduce stigma, which is not a big thing for respiratory testing, but for sexually transmitted disease testing, it might be advantageous. They can be deployed widely in various community locations, and there's a potential solution for reaching underserved or geographically isolated populations as well, with strategic distribution of these vending machines. It also offers the potential for use in a workplace health program or educational institutions like college campuses and so on. The second point I want to mention is that saliva provides an opportunity for non-centralized testing protocols, which is something we and others explored using a mobile laboratory approach. And what that looks like is shown here. Essentially, it is a small cargo van that is equipped with PCR equipment. We have a blueprint of the layout on top here. So there is a space for small footprint PCR machines that allow for on-site testing, as well as a small liquid handler that can aid in sample preparation. In the US, these vans are associated with high complexity CLIA labs, and they maintain their high complexity testing license through that association. So that enables us to deploy these to areas with low access to diagnostic testing, like community events or home care, and still maintain the high complexity license. And also these vans can be run by 2 staff members, one being a lab tech to execute the PCR protocol, and one being a community engagement lead. The third point I want to highlight is that the ease of setup and processing of saliva allows for standardized protocol development. Depending on the biomarker and the target, there's a minimal technical expertise or specialized training needed to execute those protocols, which enabled the rapid deployment and implementation in low and middle income countries and or areas with limited healthcare infrastructure. This is an example of one of these projects where we have an international implementation of a standardized protocol. In this case, it's with a partnership in Malawi. Lab technicians there were trained in executing a respiratory protocol. It's a multiplex protocol detecting SARS-CoV-2, RSV, influenza A and B in a saliva sample. And over the course of this project, since January 2024 up to September 2024, we were able to display that there is a substantial agreement in COVID, flu B, and RSV detection compared between NP swabs and saliva, and that saliva even was able to catch a second peak of flu A in this project that was missed by NP swab testing. Okay, this brings us to challenges and limitations of the method. Technical considerations that I haven't touched on is that saliva composition fluctuates based on the time of day, the level of hydration and diet. So that has to be taken into consideration depending on biomarker focus and assay development. The stability of biomarkers and analyze needs to be assessed on a case-by-case basis. I've shown you data that RNA and DNA in saliva for COVID and other respiratory diseases is relatively stable when stored at room temperature. Other markers like cortisol remain stable if the sample is frozen. So these needs to be assessed and validated on a disease-by-disease basis, essentially. The other challenge we and others are facing is that the regulatory approval and validation. For example, in the US, the CDC lists saliva as an approved sample type for COVID-19 detection. However, the FDA does not accept it as a sample type for respiratory diagnostics, which means in order to get an assay cleared by the FDA, we have to do very, very rigorous validation and clinical studies. And as a third point, the public perception and acceptance for saliva for non-respiratory disease testing remains relatively low. This already brings me to my last slide with the key points. Saliva is a non-invasive, stable sample type for a variety of biomarkers. Saliva testing has diverse applications from infections to chronic diseases. And saliva-based diagnostics offer the potential to develop cost-effective, rapid testing solutions. These methods can improve accessibility in underserved areas via different approaches like mobile laboratories and vending machines. And the challenging we still have to overcome include regulatory approval and public perception. And with that, I thank everyone very much for their attention and open it up for questions.
Thank you, Alex. That was a fantastic presentation and very timely as well. We've got lots of time left for questions, which I see are starting to come in. So I'm just going to work my way through them, and let's see how we go. So the first one is from Cyprian, and he said, would saliva be suitable for trace metal analysis?
I have to admit that is not my area of expertise. So I can't really answer that question. I'm sorry.
Okay, not a worry. Dr. Martin, saliva testing would be a great solution for pediatrics. Is there experience in the pediatric population?
Yes. So for COVID-19 testing, and specifically for the tests that SalivaDirect has been involved, we had EUA clearance for pediatric population as young as 2 years. Sometimes kids, of course, struggle a little bit with producing saliva, but overall it is possible. And even if it takes longer to produce saliva, it might still be more beneficial over NP swab.
Yeah, no, it's really interesting. Steve asks, is there a convenient internal reference for saliva, e.g. equivalent of creatinine in urine?
That's a very good question. Not that I know of. For RT-PCR, we usually use a RNase-P gene. In general, though, the saliva composition is very variable between individuals based on environment, diet, hydration status. So there needs to be a lot more research be put into what kinds of consists a baseline level across a healthy population of certain biomarkers in saliva.
Yeah, I guess that brings a follow-on question from me, Alex. How, like urine analysis, where you don't know how hydrated a person is, and therefore the volume of urine or the volume of saliva you're going to get and how diluted it is, how quantitative can saliva measurements be, or is it mostly a semi-quantitative measure that you've got?
I think that highly depends on the type of biomarker you're looking at. I can see cases, if you look at protein levels or metabolites, where it might be a more quantitative approach over a qualitative approach. Yeah.
Okay. Question from Brooke. What challenges do you see with saliva collection, such as inadequate volume? She's got two questions, so I'm going to ask her first one first. So, are there issues with inadequate volume with saliva collection?
Yeah, that's a very good point, especially if you think about the hydration status of a patient. If someone is really, really ill and with a respiratory disease, they do have trouble producing enough saliva. However, most of the tests that are currently out on the market that do use saliva as a sample type require only a very, very small volume. So it usually works out.
Okay.
But yeah, if you have a test that requires a high volume of saliva and someone who is really dehydrated, and then it is very challenging to get enough volume.
Okay, thank you, Alex. Another question from Brooke. Do you see interference in analysis with food and drink being consumed too close to the time of collection?
Yes, that also depends a little bit on the biomarker you're looking at. For nucleic acid-based assays, we definitely see interference there. And if a person, we usually recommend that people do not eat or drink for 30 minutes before providing their sample. Otherwise, it can cause invalids in the testing procedure.
Okay, thank you, Alex. Question from Christian. Do you think we will ever be able to extract enough DNA from saliva for long read sequencing?
That's a trick question. I don't think that's, I think eventually it will be possible. I think with the current technologies, we're not yet there. There needs to be a lot more enrichment. But I'm sure someone much smarter than me in biochemistry will figure it out eventually.
Okay. Question from Ricardo. Are you already testing saliva in NGS metagenomics tests? So I guess that's micro NGS metagenomics tests.
SalivaDirect is not. We did consider a project, though, that would look at NGS. The caveat there is that saliva does have its own oral microbiome, so a lot of research has to be put forward looking at the baseline. So what is normal versus what is a pathogen in the oral cavity. And there's still a large knowledge gap there.
Okay. Thank you, Alex. Question from Pilar. Have you assessed different saliva collection methods? Have you observed non-specific binding of the drug to the collection device? So there's two questions there, I guess.
Yeah, I'll answer the second one first. I personally don't have experience with drug-based saliva testing, so I can't really comment on that. But we did investigate different passive drool collection devices. There are different options. The most common one used currently is that people accumulate the saliva in their oral cavity and then just drool it into a tube, either with a little funnel or just a open tube. The other two collection methods that we looked at was using a pipette tip to drool into a tube, as well as using a ball pipette to kind of suck up the pooled saliva from the oral cavity. And we haven't observed any differences for our application across those different collection methods.
Okay. Please, for those of you online, if you have any other questions, please send them in. Meanwhile, I've got a few questions that were sent in earlier that we'll just work through with Alex at the moment. But yeah, please continue to send your questions in. Alex, what do you see as the biggest hurdle to bringing more saliva-based diagnostic tests to the market?
Yeah, thanks for that question. Yeah. So while we've seen a lot of technical advancements in biomarker discovery and everything in the R&D bucket is progressing rapidly, I believe the biggest hurdle remains in the regulatory approval and validation protocols that are associated with this. For example, again, with COVID-19, the CDC lists saliva as an acceptable sample type for diagnostics, but the FDA currently does not accept it, which puts the burden of robust and large-scale clinical trials on the manufacturers. And the FDA requires us to generate a lot of strong validation data to convince them to allow saliva. So that's been a big challenge. And I think that's a challenge that is not only a COVID or a respiratory disease facing challenge, but across a variety of diseases too. Because if you look at the R&D data, there are signatures for and biomarkers identified, but they never made it to market.
Thank you, Alex. Another question. I really like the idea of the mobile laboratory. I think that's just a brilliant idea and really exciting. Can you elaborate a little bit on the specific technologies used in that mobile laboratory for on-site quantitative PCR testing?
Yeah, let me pull up the slide. I mean, our pilot program used qPCR testing and utilized a device called MIC. It's produced by or manufactured by a company from Australia. It's a really, really small qPCR machine, the size of a shoebox. So the advantage there is that it doesn't take up much space, and it's also not prone to be disturbed by movements within the van. So that was a great product to put on this initial pilot product. In general, I would say that these vans could be equipped with any type of instrument that has a small footprint and isn't prone to be disturbed and require recalibration based on like car vibrations, for example. So you could theoretically equip the mobile lab with a variety of different technologies, like you could do an ELISA plate reader and all of that.
Wow, it's amazing. I love that. Another question we've got here: how do you ensure user compliance with at-home collections or the vending machine approach? Again, I love the vending machine. I think it's a great idea.
Let me bring that up too. Yeah, so with these test kits that are distributed through the vending machines, we also provide very clear and detailed instructions to the users on how to collect their sample. And part of the validation process for this vending machine approach is a very thorough usability study where we assess whether the subjects are able to follow these instructions accurately. And yeah, that's how we try to ensure compliance on that. And we also provide video tutorials and FAQs in case they have questions, and detailed videos outlining how to do the process. So I guess the focus is on user training first for this.
Yeah, it's very, very cool. And as you say, I think some of this anonymizing the testing process around stigma and things is a really important consideration for certain disease states that you were discussing. I think it's a brilliant potential solution for some communities. How do you see the future of saliva-based diagnostics evolving in the next 5 to 10 years?
I would like to see saliva to become more of a mainstream sample types, because we've seen from the publications that there is a wide range of diagnostic applications that could be covered by saliva. And again, it's non-invasive. It can be used for at-home testing. So we can look into all the different decentralized collection approaches, decentralized testing approaches, and just generate a lot more accessibility and also faster time to results if we focus on saliva. The other thing that any of these accessibility methods might enable us to do, and which I think is a really, really cool idea, is the integration with telehealth and personalized health monitoring, which would be enabled by using saliva in this capacity. And additionally, I know that there's a lot of work going on developing point-of-care devices that can use saliva, which again would be a great addition also to the mobile laboratory approach. So overall, I think saliva has a very, very broad application and a lot of possibilities. We just need to move forward and harness those.
No, I think it's really interesting. And Alex, thank you so much for the broad education in saliva and around diagnostics. It looks like we've not got any further questions. So if you don't mind, Alex, I'm just going to go through a couple of slides to do with PCSIG. But if anyone does pop any questions in, we can come back to them in a moment. Oops. I'm just going to put the presentation back up again because... So just for everyone, we've got a bunch of webinars booked. Well, we're actually booked through until May 2026, but the ones that are coming up imminently, we've got Riddhi Tarial from Next Generation Jane and Soren Therkelson from Kivin are going to be talking to us on the 17th of April. We've not got a confirmed title yet, but basically both of their technologies use menstrual blood as an alternative sample source. So building on this, not just looking at standard venous blood, on top of what we've been looking at with saliva here today, looking at menstrual blood as a sample source. So tune in for that on 17th of April. Registration should be open by the end of the week. Out on the 30th of April, we've got the PCSIG alcohol consumption study team that ran a study over the last few years looking at whether home sampling versus in-clinic sampling affects the rate of recruitment and retention. I noticed there's some people on this call that were part of that study in the early days. We'll be making a presentation on the output of that, which is very exciting, on the 30th of April. And then on the 21st of May, Ben Herbert in Australia from Sangui Bio will be talking about proteomics home sampling for colorectal cancer screening. So he's going to be staying up late in the middle of the night. So please make sure you attend and see him in his pajamas. So just a little bit about the patient-centric sampling interest group. If we've got any new people here that aren't aware of our group, we try to bring together any sample type, whether it's saliva, urine, menstrual blood, normal blood or serum or other sample types, looking to bring forward technologies that put the patient at the center rather than other people's needs. If you're interested in learning more, please contact us, visit our website using that QR code, or join our LinkedIn group using that QR code. Just one last thing, to thank all of our partners and sponsors and the evidence base for giving us the platform to speak to you all today. Very much like to, I'm just checking there's been no more questions. No more questions. Just very much like to thank you, Alex, again for your wonderful presentation today, and your colleagues at SalivaDirect for making this such a pleasurable experience. And thank you to all of our attendees. The video of this will be available in the next few days on YouTube and through our website and through the evidence base. So thank you for all for your attendance today.